Welcome to This Explainer. Today, we're diving into the incredibly complex clinical journey of managing parotid gland tumors. We're basically going to act as medical detectives today, solving a really high-stakes mystery that starts with a simple, mysterious lump and ends right there in the operating room. Now, the parotid gland is the absolute largest of our salivary glands. It sits right in front of the ears. And when something goes wrong in that area, well, the anatomy is just so intricate that it requires a highly strategic approach. Let's get into it. Okay, here's our roadmap for the day. First up, the parotid tumor mystery. Then, spotting the red flags. Moving into the diagnostic detective work. Surgical battle plans. And we'll wrap up with complications and follow-up.
Section 1. The parotid tumor mystery.
So, our journey really begins the exact moment a patient walks in with a mysterious mass in the parotid region. But here is the absolutely crucial thing to remember. Not every mass is a tumor. Before we go jumping to conclusions about cat parotid, which is just clinical shorthand for parotid cancer, we have to run through a pretty wide differential diagnosis. I mean, are we looking at a viral infection, like mumps? Is it a bacterial issue, maybe tuberculosis? Could it be an autoimmune condition like Sjogren's syndrome? Or, honestly, just a benign fatty lump, a lipoma? We literally have to rule all of these usual suspects out first.
To narrow down those suspects, we really need to look at the patient's background. We're hunting for key risk factors that might tip the scales toward a true tumor. So we ask, has the patient had any prior radiation exposure to the head or neck? Do they have a heavy history of smoking or alcoholism? Are there genetic predispositions at play? Or maybe some specific environmental exposures? All of these little details are clues that help us build our case.
Once we actually suspect a true neoplasm, which is just a fancy word for an abnormal growth of tissue, we hit a major fork in the road. It's the great divide of tumor types. On one hand, we have the common benign culprits, things like pleomorphic adenomas, which are the most frequent offenders, alongside Warthin's tumor and oxyphilic adenomas. But on the other hand, we have the really dangerous malignant offenders. We're talking Mucoepidermoid carcinoma, Adenoid cystic carcinoma, acinic cell carcinoma, and this super deceptive one called carcinoma x pleomorphic adenoma, which is basically a benign tumor that suddenly decided to turn bad. Moving on to Section 2, spotting the red flags. As we keep digging into this investigation, we absolutely need to know which clinical signs point straight toward those malignant, dangerous tumors we just talked about. If a patient comes in and you notice a sudden, rapid increase in the size of the mass, yeah, red flags should be flying. But check out these other symptoms: facial weakness, paresthesia, which is that tingling or numbness, trismus, meaning a locked jaw, or even hoarseness and difficulty swallowing. Now, why does all that happen? It's because the facial nerve, along with other critical cranial nerves, runs right through and around the parotid gland. So if a tumor is malignant and aggressively invading the surrounding tissue, it wreaks havoc on those nerves, causing severe functional problems. You might even see snoring if enlarged lymph nodes in the neck start blocking the airway.
Section 3. The diagnostic detective work.
Okay, so how do we safely confirm our suspicions without accidentally spreading a potential cancer? We follow a very strict 3-step protocol. Step 1, of course, is a thorough clinical history and physical exam. Step 2 involves imaging, usually starting with an ultrasound, paired with an FNAC, which stands for fine needle aspiration cytology. Basically, we use a tiny needle to grab some cells. Now, if we think the tumor goes into the deep lobe of the gland, we'll upgrade to a CT or an MRI. And if we suspect nerve involvement, remember all those red flags we just talked about? An MRI is absolutely essential to check for perineural spread. Finally, step 3 is prepping for surgery and doing a complete staging workup to see if this thing has spread anywhere else.
When the lab gets those cells from the needle aspiration, pathologists use something called the Milan system to grade them. Think of it as the ultimate decoder ring for cytology results. Category 1 means it's non-diagnostic, so we just have to do a retest. Category 2 is non-neoplastic, no tumor, so we just monitor them. Category 3 is AUS, atypia of undetermined significance. That basically means the cells look a little weird, but they aren't definitively cancer, so we either repeat the test or go to surgery. And finally, categories 4A and 4B confirm it's either a benign or malignant tumor, which tells us, right, it is time to prep the operating room.
Before we take all these clues into the OR and really escalate our battle plans, I just want to take a quick second. If you're finding this explainer helpful and you're enjoying diving deep into this kind of structured medical mystery with us, please take a moment to like, share, and subscribe. It really goes a long way in helping us bring more of these deep dives straight to you. All right, Section 4, surgical battle plans. So, diagnosis is confirmed, staging is done, it's time to map out the surgery.
Now, the parotid gland actually has a superficial lobe and a deep lobe, and they are separated by the facial nerve. That makes this surgery incredibly, incredibly delicate. Our interventions scale up based on the size of the tumor. For T1 staging, so smaller tumors under 2 centimeters that haven't broken out of the gland itself, a conservative superficial parotidectomy is the gold standard. We carefully preserve the facial nerve. For T2 tumors, which are between 2 and 4 centimeters, we might step it up to a total conservative parotidectomy, removing the deep lobe as well, and sometimes we'll add radiation. But when we hit T3 and T4 staging, things get much more dire. These tumors are either larger than 4 centimeters or they're actively invading the skin, the jawbone, the ear canal, the nerves, or worst case, the skull base. At this point, the battle plan escalates dramatically. We're looking at a total or radical parotidectomy, and unfortunately, preserving that nerve might no longer be an option. We also bring in ELND, which is an elective lymph node dissection in the neck, and then we follow up with adjuvant radiation to wipe out any microscopic cancer cells that might have been left behind. Just to touch on that cleanup phase, to make absolutely sure no microscopic enemies are left behind, we deploy adjuvant radiation and lymph node dissection for very specific high-risk indicators. If the pathology report shows a high-grade aggressive tumor, if the tumor is recurrent, or if the surgical margins were just a little too close for comfort, we radiate. Plus, if there is evidence of perineural spread, meaning tumor cells are actively traveling along the nerves, or if the lymph nodes actually test positive for cancer, a comprehensive neck dissection and radiation therapy become absolutely mandatory. And our final section, number 5, complications and follow-up. The surgery might be over, and the tumor is out, but our patient's journey, it's not finished yet. Navigating the complex anatomy of the face means risking some very specific, tough complications. Because surgeons are working right on top of the facial nerve, there's a real risk of facial palsy, causing temporary or sometimes permanent drooping of the face. We also have to watch out for hematomas, seromas, post-op infections, and siloceles, which is basically a pooling of saliva under the skin. But there is one highly unique and honestly kind of fascinating complication known as Fraze syndrome. So what is Fraze syndrome? It's this bizarre phenomenon known as gustatory sweating. See, when the surgeon removes the parotid gland, the tiny parasympathetic nerves that used to tell the gland to produce saliva get severed. When those little nerves grow back, they can get confused and accidentally wire themselves into the sweat glands in the skin of the cheek. The result? A patient will actually start sweating from their cheek while they're eating. It's wild, but surprisingly, it can be treated with anticholinergic meds, targeted Botox injections, or literally just everyday antiperspirant applied right to the cheek. Finally, we have to keep a very watchful eye on our patient using a strict follow-up timeline. For the first 5 years, we combine clinical exams with radiological imaging, like ultrasounds, CTs, or MRIs, every single 6 months. It's intense. But once they've cleared that critical 5-year mark without a recurrence, we can finally space those visits out to once a year for the next 5 years. It's definitely a long road, but it's exactly what's needed to ensure we catch any returning threats immediately.
As we wrap up this explainer, I want to leave you with something to think about. As our diagnostic detective work keeps getting sharper with higher MRI resolutions and our surgical tools become more microscopic and precise, will we soon see a day where the severe complications of parotid surgery, like facial palsy or Fraze syndrome, are completely a thing of the past? It is a truly fascinating frontier in head and neck surgery. Thank you so much for joining me on this clinical journey. Keep on learning, and I will see you in the next explainer.